So today we're going to be discussing the role that hypoxia plays in the pathogenesis of Duchenne muscular dystrophy. So briefly, the natural history of DMD is one that is marked by a slow onset of skeletal muscle weakness, which begins very early in life and progresses throughout the course of the disease. Eventually, patients will become wheelchair-bound at some point. Some later time, or around that same time, ventilatory support is also required. What's important to note, though, about the ventilatory support is that prior to that, there are periods of subclinical hypoxia. This is a reduction in oxygen that is a result of their inability to breathe, to ventilate properly, to get new oxygen into their lungs. And we feel that this is a very important aspect of the disease process that perhaps is contributing to the acceleration of either the skeletal muscle and or the cardiac disease. And of course, cardiac dysfunction is progressive in onset as well, tends to be a little bit later than what we see with skeletal muscle. However, what's important to note is that by the time you have lots of injury here, the damage is already done. And so what we really would like to be able to do is to prevent that damage in the first place. So what do we know about the prevention of cardiac injury in Duchenne muscular dystrophy? Well, there's a few things that we know that damage the heart. It's a progressive disease. The older the patient, the worse in general the cardiac function tends to be. Increases in workload, so either increasing heart rate or increasing the blood pressure, so the heart has to work harder in order to pump blood. Both of these things have been shown in mouse models and to some degree in patients to play a role in the acceleration of the disease process. There are a variety of molecular interruptions that we've been able to identify, primarily in mice, that suggest that may accelerate the disease process, particularly in dystrophic hearts, but also in skeletal muscle. So one of those is utrophin. So if we take utrophin away, you get a very severe phenotype within mice. And there's some talk that increasing utrophin may actually improve the functionality of dystrophic muscle. Alterations in integrin expression have been shown to alter cardiac phenotypes and skeletal muscle phenotypes, altered glycosylation patterns, differences in calcium handling proteins, mitochondrial targeted proteins, regulators of fibrosis. And what I hope to show to you today is that we should add hypoxia to this list, is that the introduction of hypoxia is sufficient to accelerate the cardiac disease present in Duchenne muscular dystrophy. So this observation stems from several studies that we performed in mice. Here we show with acute hypoxia, so MDX mice develop a significant acidosis. So what we can see here is that in the black are the C10s. These are normal mice with a similar genetic background as our MDX mice. And so under normoxic conditions, when there's plenty of oxygen around, you can see here that there's about 100 millimeters of mercury of oxygen present within the arterial blood of both MDX and control mice. When we introduce hypoxia with this plus, you can see that that level drops dramatically, and we have a marked reduction in oxygen content of the arterial blood in both of these animals. When we look at the pH of the blood, the pH is very important because it modulates a lot of different enzymes, their functionalities, and it's something that the body tends to protect with significant buffering capacity. So it takes a big change to move the pH because the physiological consequences are so severe. And you can see in a wild-type mouse, when we introduce hypoxia, with the plus here, you can see there's not a big change in the pH. The pH doesn't really shift all that much. However, when we look at the MDX mouse, when we introduce hypoxia, we have a dramatic reduction in acid and pH, suggesting a development of acidosis. The blood is becoming more acidic. Importantly, we demonstrate that this is not due to problems with them breathing, and that it likely results from increased lactate production, primarily by skeletal muscle. when we look at the dystrophic hearts, trying to understand what might be going on in the dystrophic heart during hypoxia, what we find is that the dystrophic heart has a reduction in cardiac efficiency. So what this means is that it requires more oxygen to do the same amount of work. At the same time, these dystrophic hearts are less able to utilize that oxygen. So you can see here a wild-type mouse, the C57 Black 10, is able to extract over 70% of the oxygen that is delivered to it in the perfusate. So when we give hearts oxygen, a wild-type heart can extract 70% of that oxygen. When we look at the dystrophic mice, what we find is that there's a marked reduction in the amount of oxygen with which they are able to extract. This suggests that there's something wrong with their ability to utilize this oxygen. So now we have this state where we have these mice that their hearts need more oxygen, yet they are less able to utilize that oxygen that is delivered to them. And this becomes, we think, significantly important when the oxygen levels are reduced, suggesting that perhaps the ability of these hearts to extract oxygen becomes limiting during hypoxic conditions. So we performed another study where we took dystrophic mice, MDX mouse, and some C10 mice, and we exposed them to hypoxia for a relatively long time, so 3 weeks of exposure to hypoxia. And what we observed when we did this is that after 3 weeks of hypoxia, you can see a significant development of fibrosis. So this red here is all myocytes that have been replaced by scar tissue. So this level of scarring would be expected in a very old mouse, for example. And this is the type of disease that we see in dystrophic dogs and also in patients, where you have lots of scarring, lots of replacement of muscle tissue with this fibrosis tissue. But this mouse is only 3 months, this mouse is 4 months old, so he's not very old. He should not have any scarring, really. And an MDX mouse not exposed to hypoxia looks very much like this control mouse over here. There's very little evidence of fibrosis. So this really suggested that hypoxia alone is sufficient to accelerate the cardiac disease in the mouse model of Duchenne muscular dystrophy. So the next little bit, I want to talk about some of the normal physiology of breathing so that you can appreciate some of the therapeutic approaches that we are proposing in this study. So here, this is a little cartoon that we use to sort of explain respiratory physiology. And so what this is going to be our lung. This could be your trachea or your windpipe coming in. And so when you breathe in, you have all this gas coming in. Most of it's nitrogen, which are these little green dots, but some of it is oxygen. So about 20% of your air that you breathe in, of the molecules you breathe in, are oxygen, these little red guys here. And so one of the ways that we think about how oxygen is transported through the blood is we think of little red blood cells, and the little red blood cells can be depicted as little train cars. And so these little train cars can fill up with oxygen. So these purple dots here that you can see are carbon dioxide. So these are released by the tissues and brought back to the lungs by the venous circulation. And so that carbon dioxide will diffuse into the lungs, and this oxygen will diffuse out of the lungs. So we can see that happen here. So what's going on is that we have a increased oxygen is saturating our little train here. So we have lots of oxygen present, and you see there's some dissolved oxygen, and the CO2 is present within the lungs. And that oxygen will move on, and then we can exhale, and all of that happens. Okay, so this is the case with normal breathing. So now we want to think about dystrophic breathing. So in the dystrophic patient or in a mouse, you breathe in the same level of oxygen, the same level of nitrogen, and that will proceed along. You have the normal amount of carbon dioxide coming in. You'll have a transfer of oxygen very similar to what we saw in normal patients. Now, what's different with healthy patients versus dystrophic patients is dystrophic patients won't breathe as often, is so they have poor ventilation, so they don't switch out this gas as often as they should. So now, instead of exhaling at this point, let's say they breathe a little bit less, and so now you have more CO2 coming. And when we look at this, we have a significant increase in CO2, which is a very important point that we'll need to discuss a little bit later. But what you'll notice here is we have a marked desaturation of our hemoglobin, of our red blood cells, as they're not all full anymore. And this could be a significant problem, because now when they take this oxygen off to the tissues, they're delivering much less oxygen. Okay, so this is also important because this state of hypoxia is very common in Duchenne patients. The standard practice is generally that patients don't get evaluated for respiratory disease or respiratory insufficiency. They certainly don't start therapy until there's evidence of some sort of sleep disruption. Is really the first symptom that drives people to seriously consider whether they should institute ventilatory support, at least nocturnally. So the dilemma with this is that this sleep disruption is rather late in the game, is that there has to be a fair amount of hypoxia for this to occur. And when those bouts of hypoxia, those subclinical hypoxia that we talked about earlier, occurs, it increases the cardiac activity, it increases the heart rate, it increases the strength of contraction. Even in healthy hearts, this type of hypoxia, when we think of like sleep apnea and things like this, even in a healthy heart, that can result in significant cardiac damage. And then you do the same thing to a dystrophic heart. It seems reasonable to expect that too might cause the dystrophic heart increased damage. And as we've demonstrated previously, the hypoxia alone is sufficient, even in the relatively mildly affected dystrophic mouse, to cause significant cardiac disease. Now, unlike all of the other molecular pathways that we discussed, we have the ability right now, right today, to significantly reduce the amount of hypoxia that patients are experiencing. So this, as I mentioned earlier, we have these clinically accepted. This is the important point here, is that these are practices that are done every day in the clinics, in patients, whether we start them later in the disease course or earlier in the disease course, or perhaps maybe not instituting ventilatory support, but perhaps just increasing oxygen for a few years might be something that we could might be beneficial to the heart ahead of time. We don't need FDA approval as such, because these are all been proven safe and effective. Well, safe. We're working on the effective part. Alright, so let's think about what happens when we add dystrophic breathing with extra oxygen. So now we've got our lung and our trachea coming in. Now what you'll notice, if you're paying attention, is that there are a lot more red dots in here. So what we've done is we've either increased the concentration of oxygen, as is probably demonstrated here, or we could also do this by increasing the pressure of the gas around here, which will just pack in more gas in here, but the net effect is you'll have more oxygen within the lung. So now when our little blood train comes along, the CO2 will diffuse in and oxygen will diffuse out. And you can see that we've completely saturated the entire amount of red blood cells, and so that will carry on. So now if we are a dystrophic patient and we're not ventilating appropriately, we don't change out this air, but we still have a lot of oxygen left. And our CO2 will come into our lungs now, and our oxygen. So we maintain our oxygen delivery to the tissues. Now, it is very important to note that we have an increase in carbon dioxide in the lungs. And over time, this can become a very serious problem. Especially if hypoventilation becomes markedly depressed. One thing, though, the body is a very dynamic organ, is that it has other ways of getting rid of this carbon dioxide. For example, the kidneys can excrete carbon dioxide and acid very effectively, but it's a slower process. So this is potentially an important issue, is that if hypoventilation becomes so bad that the CO2 is building up too quickly, then we need to seriously think about improving ventilation, and hypoxia or improving oxygen content alone will not be sufficient. However, we think that early on in the disease course, when the body is still coping okay with the acid balance, and that it's really the oxygen that might be that is causing the disease process, it may be that just increasing supplemental oxygen or other methods of increasing oxygen within the lungs could provide a method to sort of bridge these patients, so they don't have to go straight to ventilatory therapy. They might go to sleeping with a little mask on that just increases the oxygen that they breathe, or sleeping in an oxygen tent type of thing. So these are sort of the crux of what we're proposing here. All right. So the current proposal as it is to really examine how supplemental oxygen improves cardiac function and structure with challenge. So we will essentially assess, we use a variety of cardiac stressors to increase the stress of the heart. We want to see how, if oxygen delivery is actually improved in these mouse studies. We'll also look at skeletal muscle function. How well do they recover from bouts of exercise? How well does it improve respiratory diaphragm function? These are all things that we are particularly interested in understanding, is that if we increase the oxygen delivery to the tissues, are we then able to slow the progression of the disease process? So in these studies that we're looking at here, we're looking to increase oxygen in two ways. One is by just increasing the fraction of oxygen. So this would be using an inhaled oxygen or an oxygen tent type of paradigm. And the other is to increase the pressure of the air. And this would be sort of a hyperbaric paradigm where we increase the pressure. And we might also increase the oxygen as well during these high pressure states to really try to amplify the amount of oxygen that we're getting into the mice. So that's sort of the gist of this study. There's a few people we have to thank. So Jar of Hope has been sort of a leading driver of this project, thinking about how oxygen may be used as a therapeutic. The Duchenne Alliance, which is hopefully you guys are familiar with if you're seeing this, is a organization that allows small foundations to get together and to fund important studies. My laboratory is also funded by the National Heart, Lung, and Blood Institute from NIH, and we also have a grant from MDA looking at this hypoxia question. The MDA grant is primarily trying to understand the molecular mechanisms of hypoxia. How does hypoxia cause the injury in the first place? This grant would be a little bit different in that we're really just going after a therapy. Can we find this? Is this an effective way to treat this disease? Of course, we had the MD Center at the University of Minnesota, so a vibrant group of investigators focused on trying to understand Duchenne, trying to understand muscular dystrophies as a whole, and trying to develop new therapies for that. So with that, I thank you, and I hope that you are interested in supporting this project, and thank you very much.